thanks again, and thanks for selecting the abstract as presentation. My disclosure didn't change in 10 minutes. And we have seen before the 3 randomized clinical trial showing superior progression-free survival of first-line ibrutinib-based therapy versus standard of care chemoimmunotherapy. And now I will present the data of the RESONATE-2 trial with a long-term follow-up up to 5.5 years. And to evaluate long-term follow-up is important to inform clinical practice, not only for efficacy, but also for safety, considering that ibrutinib is given as a continuous treatment. And considering the limitations of in vitro kinome assays, long-term clinical data are critical also to understand the efficacy and safety profile of BTK inhibitors. The RESONATE-2 is a phase 3 randomized clinical trial designed to evaluate safety and efficacy of ibrutinib given continuously until progressive disease or unacceptable toxicity versus chlorambucil monotherapy on days 1 and 15 up to 12 cycles. Patients, of course, were in first-line treatment were aged 65 years or more, and 70p deleted patients were excluded from the study because one arm was represented by chlorambucil. Patients showing a progressive disease after chlorambucil were allowed, after showing a progressive disease IRC documented, to be enrolled in the 1116 study and receive ibrutinib as salvage treatment. And as for now, 57% of patients cross over to receive ibrutinib. Patients and disease characteristics were well balanced between the 2 arm groups. Just to point out that although 70p deleted patients were excluded from the study, there was a small proportion of patients with unmutated, with TP53 mutation. The majority of these patients were enrolled in the ibrutinib arm. A high prognostic risk group represented by patients having at least one or more high-risk genomic features such as TP53 mutation, 11q deletion, or unmutated were 54% and 52% in each arm group. Median duration of ibrutinib treatment to date in the study is 57 months, and with an up to 5.5 years of follow-up, 58% of patients are continuing on ibrutinib on this study. And the most common reason for treatment discontinuation was adverse event, 21% of patients, and only 8 patients, that is 6%, showed a progressive disease during ibrutinib treatment. Progression-free survival benefit was sustained with ibrutinib when compared to chlorambucil with this long-term follow-up, with a reduction in risk of progression of death by 85%, median progression-free survival not reached versus 15 months, and an estimated 5-year progression-free survival of 70% versus 12%. Of the 20 patients enrolled in the ibrutinib arm, including patients who had previously discontinued ibrutinib, 20 patients progressed at any point, and only 8 of them progressed during ibrutinib treatment. Ibrutinib maintained also improved overall survival, although 57% of patients cross over to receive ibrutinib. If we focus on patients with high-risk features, ibrutinib dramatically reduced the risk of progression of death in 11q deleted patients. And if we look at patients enrolled in ibrutinib stratified according to the 11q deletion, we can see a trend towards a better progression-free survival in patients showing 11q deletion versus patients without the 11q deletion, 79% versus 67%. Ibrutinib also reduced the risk of death or progression in unmutated patients, and there was a similar progression-free survival when patients were stratified according to the mutational status. The adverse events the prevalence of adverse events decreased over time. No new safety signals emerged during long-term follow-up ibrutinib treatment. And you can see that on the right, the prevalence of grade 3 or higher adverse events. The differences of some adverse events like arthralgia and cataract may be related to the characteristic of population enrolled in the trial, consistent with the arising of age. Consistent with the adverse events that were mostly seen in the first year, dose reductions and discontinuation were most frequent and most common in the first year of treatment. 27 patients experienced adverse events leading to dose reduction, and 93% of them had an improvement or resolution of the adverse events. This demonstrating the role of treatment and dose reduction to enable patients to continue to receive a benefit from ibrutinib treatment. And ibrutinib dosing was held for 7 or more consecutive days for adverse events in 70 patients. 86 had a complete resolution of the adverse events following a dose hold, and the majority of patients restarted ibrutinib, and 42 at the same dosage. Median overall survival has not been reached in the 21 patients discontinuing ibrutinib due to adverse events, while median overall survival has been reached after 20 months in the only 8 patients discontinuing ibrutinib due to progressive disease. And considering altogether the population of patients discontinuing due to any cause other than death, median overall survival has not been reached, and 69% of the patients are still alive. Patients responded to subsequent therapy after ibrutinib discontinuation on treatment based on chemotherapy, or novel agents. We have, as for now, responses in 9 of the 14 patients, and 7 patients responded. So we can say that after this long follow-up, that is 5.5 years, and is the longest from a phase 3 study of first-line BTK-directed treatment, single-agent ibrutinib confers sustained progression-free survival when compared to chlorambucil, with a 5-year progression-free survival estimated at 70%. The rate of progression was very low, considering that only 8 patients progressed while actively on ibrutinib, and no new safety signals emerged with long-term follow-up, and many adverse events decreased over time. Active dose management, like dose holds and reductions, may enable most patients to continue on ibrutinib treatment. So at this moment, nearly 6 out of the 10 patients remain on ibrutinib at a median follow-up of 5 years of follow-up. The results and the follow-up of the study will be published on leukemia and has been recently accepted. We would like to thank again all patients, all the families, and all the investigators and the staff of the study centers, and thank you again for your attention.